Patients here.
Oh boy, got some blood going.
Yeah, this is with blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over, her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application
in your left
hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. I'm really glad you're here with us. Today, we're doing something a little bit different. Usually, we take a topic and sort of wander through the philosophy or the tech trends, but today, we have a very specific, very tactical mission.
We do.
We're taking this massive stack of sources. I mean, clinical overviews, pathogenesis papers, CDC protocols, nursing textbooks, and we're going to transform those dry, dense pages into what we're calling the Pediatric Nursing Exam Cram.
It's a really specialized session. We're essentially building the ultimate study guide for a disease that, quite honestly, a lot of people, a lot of students think belongs in a history book.
Right.
But if you actually look at the data, and, well, certainly if you look at the nursing board exams, this topic is very, very much alive. We're talking about measles.
Or, to get clinical about it.
Or to be clinically precise, rubeola.
Rubeola. And before you, the listener, tune out thinking, oh, I know what measles is, it's just a rash. Hold on. Because this is the exam writer's darling.
Oh,
it really is.
Absolutely.
The sources we looked at make it so clear that this disease is a favorite for testing critical thinking.
Oh, 100%. If I'm writing a test question, for the NCLEX or for a pediatric board exam, I love measles.
That sounds just a little bit sadistic. Why do you love it?
Because it tests everything at once. I mean, in a single clinical scenario, a kid with a fever and a rash, I can test your knowledge of isolation precautions. I can test you on vaccine schedules. I can test your ability to spot contraindications. I can test you on public health reporting. Yeah. It's the perfect storm. It forces you to integrate safety, pharmacology, and pathophysiology all in one go.
Okay, so our goal today is to make you bulletproof on this topic. Whether you're prepping for a final, the NCLEX, or you just want to be the sharpest clinician on the unit, we're going to break this down. Here's the roadmap. We're going to start with what we call the master 80-20 map. These are the patterns you need to recognize instantly. Then we're going deep, much deeper than a cheat sheet into the system-by-system lecture. We'll look at the Trojan horse, pathophysiology, the presentation, and the management.
And we can't forget the developmental impacts. I mean, that's huge.
Yeah.
Dealing with a measles patient who is 2 years old is completely different from dealing with one who is 10. We'll cover how to handle the isolation psychologically.
Yes. And finally, we will wrap up with the nice-to-know history and some tricky differentiations to keep you from getting fooled by other, rash diseases on an exam.
It's a full agenda.
It is.
Yeah.
So let's jump right in. Section A, the Master 80-20 map. If a student or a nurse only retains about 5 minutes of this entire deep dive, what is the one pattern they need to burn into their brain? What's the measles signature?
Okay, the signature pattern is this. A high fever prodrome plus a descending rash. You have to have both of those components.
High fever prodrome, descending rash.
Yes. So if you see a question description of a child who is just absolutely miserable, toxic looking, with a high fever, we're talking 103, 104, even 105 degrees Fahrenheit.
Wow.
And then, and only then, a rash starts on the head and moves down. You stop. Do not pass go. You have to think measles until it's proven otherwise.
I want to stick on that descending part for a second because, a lot of rashes spread. What makes this one so unique?
It's the gravity of it. It literally starts at the hairline, behind the ears, and it just washes down the body like you poured a bucket of paint over the kid's head.
That's a great video.
It hits the face, then the neck, then the trunk, then the extremities. It doesn't pop up randomly on the belly first or on the legs. It is a top-down invasion.
Okay, so high fever first, rash later, moving down.
Got it. Now, let's talk about the safety decision point. This is the can't-miss item. If you suspect this pattern, what is the absolute first thing you do? Before you even take a temperature, before you call the doctor, you isolate them immediately. But this is where people fail the exam, and frankly, this is where they endanger the entire unit. You don't just put them in a private room.
Right.
You need airborne precautions.
Okay, this was the part of the research that honestly terrified me. The sources mentioned something called the 2-hour rule. Can we unpack that? Because airborne sounds like a buzzword, but the physics of it are genuinely scary.
It is scary, and you're right to be. So most respiratory bugs, like, say, the flu or RSV, they travel on droplets. You cough, a heavy wet droplet flies out about 3 feet, and then gravity just pulls it to the floor. If I'm standing 6 feet away, I'm generally safe.
Okay.
Measles is completely different.
How so?
Measles travels on what are called droplet nuclei. So imagine the droplet comes out of the person's mouth, but the water in it evaporates almost instantly.
Huh.
What's left behind is this microscopic, lightweight viral core.
So it's not wet anymore.
No, it's dry. And because it's so light, it doesn't fall. It floats. It just rides the air currents in the room. It's like dust motes you see floating in a sunbeam.
So it's just hanging there.
Exactly. And the source data is really explicit on this. These viral nuclei remain viable and infectious in the air for up to 2 hours after the infected person has left the room.
2 hours. Okay, I want to role play a scenario because this really drives it home for me. Let's say a mom brings her kid into the ER. He's coughing, looks sick. You triage him, you think maybe it's the flu, you put him in exam room 3, he's there for 20 minutes, then he leaves.
Okay, following.
An hour later, so 60 minutes have passed, the room is empty. I'm a nurse. I walk into exam room 3 to clean it or stock supplies. I'm not wearing a mask because, well, the room is empty. Am I in trouble?
You are in serious trouble. If you are not immune to measles, there is a 90% statistical probability, that's the attack rate, that you will contract the disease just by breathing that air.
A 90% chance from an empty room.
You're walking into a cloud of invisible virus that is still just waiting for a host.
That is sci-fi horror movie stuff. It's like catching a disease from a ghost.
It is. And that is why the isolation protocol is so incredibly strict. It has to be a negative pressure room, which actively sucks the air out and filters it so it can't drift into the hallway.
Right.
And you, the provider, must wear an N95 mask, which is fitted to seal against your face. A standard surgical mask has gaps on the sides. Those little nuclei will float right in.
So the takeaway for the 80-20 map, if you even suspect measles, you don't wait for the lab result. If the clinical picture fits, you isolate airborne immediately.
Correct. It's a guilty until proven innocent situation when it comes to isolation. You cannot risk it.
Okay, we have the isolation down. What about the assessment cue? If I'm looking at this kid, besides the super high fever, what are the specific signs that scream measles?
You are looking for the 3 C's.
I love a good mnemonic. It saves lives on exams, I swear.
It's a classic for a reason. It's cough, coryza, and conjunctivitis.
Okay, let's break those down because cough is pretty generic. A lot of things cause a cough.
That's true, but the texts describe it very specifically as a hacking cough. This isn't a polite little clear your throat cough.
Yeah.
It is deep, it is harsh, and it just sounds exhausting, like the kid can't catch their breath.
And coryza, that's a fancy word.
It is. It's just medical speak for inflammation of the mucous membranes in the nose.
Yeah.
So basically, a profoundly runny nose. They're just dripping constantly.
Got it. And the last C, conjunctivitis.
Pink eye. But it's usually bilateral in both eyes. They're red, watery, really irritated eyes. And often this is a key symptom. They are photophobic.
Meaning light hurts them.
Light physically hurts their eyes. So you have this kid who is hacking, snotty, with red, weepy eyes, and they're miserable with a fever, and they want the lights turned off.
That's a very specific picture.
It is. And then there's the smoking gun, the thing that shows up before the rash on the body.
The ananthem, the spots inside the mouth.
Couplet spots.
Couplet spots.
Yes. We'll detail the adherence in a little bit, but if you look in the mouth and you see these specific spots, you have your diagnosis. You don't even need to wait for the rash on the face to appear.
And the last item on our 80-20 map, the can't miss safety item. This surprised me when I was reading the sources. It wasn't an antibiotic or some fancy antiviral. It was a vitamin.
Vitamin A?
Why? Is this just, holistic nursing? Take some vitamins and feel better?
No, this is hardcore physiology.
Yeah.
The measles virus is brutal on epithelial cells, the lining of your gut, your lungs, and especially your eyes. It rapidly depletes the body's store of vitamin A.
Okay.
And when vitamin A levels drop, the immune response weakens and the risk of blindness skyrockets.
Blindness from measles.
Yes, corneal scarring. The virus directly attacks the eye, and without enough vitamin A to help repair that delicate tissue, the damage becomes permanent. So high-dose vitamin A is a standard medical order for severe measles to prevent blindness and actually to reduce overall mortality.
So to recap the 80-20 map before we go deeper, high fever plus a descending rash. Airborne isolation, immediately remember the 2-hour ghost rule.
Yep.
Look for the 3 C's and Koplik spots. And keep vitamin A in the front of your mind as a treatment priority.
That's the cheat sheet. If you know that, you are safe in the room. Now let's get into the weeds.
Okay, let's do it. Let's move to section B, the system by system lecture. We always like to start with a one-liner. If you had to describe measles to a colleague in just one sentence, what is it?
Okay, my one-liner would be, measles is an acute, highly contagious viral respiratory illness, specifically a paramyxovirus characterized by a high fever prodrome, a specific mouth ananthem called Koplik spots, and a generalized maculopapular rash.
You really emphasized respiratory illness again there.
I did.
But everyone thinks of it as a skin disease because of the rash.
That is the single biggest misconception. The rash is just the billboard. It's the advertisement for the disease. But the disease itself is respiratory. The transmission is respiratory. The entry point is respiratory. The major complications are respiratory.
Okay, so let's walk through that patho in plain language. The virus is the invader. How does it get in? You said it's respiratory.
You breathe it in, those little droplet nuclei we talked about. The virus goes down the trachea into the lungs and lands in the alveoli, the tiny air sacs.
Right.
Now, usually you have immune cells down there called alveolar macrophages patrolling. Think of them like the security guards or the Roombas of the lungs, just cleaning up debris.
So the security guard sees the virus and eats it. Problem solved.
Well, it tries to. But the measles virus is incredibly clever. It uses the macrophage like a Trojan horse. It actively infects the very cell that is supposed to kill it.
That's insidious.
It is. It hijacks the machinery inside the macrophage, starts making copies of itself, and then it rides that macrophage to the local lymph nodes.
So it uses the security guard to get a free ride into the police station.
Exactly. That whole process takes about 2 to 3 days. This is part of the incubation period. The patient feels totally fine. But inside, the virus is replicating like crazy in those lymph nodes. Then it bursts out into the bloodstream. We call this primary viremia.
And they still don't have symptoms.
Maybe a little fatigue, but nothing specific. The virus then spreads to what's called the reticuloendothelial system. So the spleen, the liver, the bone marrow. It sets up shop there and just amplifies. It makes millions upon millions of copies of itself.
It's building an army.
It absolutely is. And then around day 5 to 7, after that initial infection, you get secondary viremia. Wow. This is the massive wave. The dam breaks, the virus floods the blood, it goes everywhere. Skin, kidneys, the GI tract, and crucially back to the lungs in massive numbers.
And this is when they get sick.
This is the prodrome.
Yeah.
The viral load is peaking. The immune system is freaking out. The respiratory lining starts shedding virus like crazy. When that kid coughs now, they are a biological weapon.
Yeah.
They're just spraying aerosolized virus everywhere.
Let's put this on a timeline because exams love day X questions. So the source says incubation is about 11 to 12 days.
Right. That's the silent period. From the moment they breathed it in at the airport or the playground to the very first symptom, 11 to 12 days, nothing.
Then we hit the prodrome. This is the warning phase.
Yep. And this lasts about 2 to 4 days. This is where the kid looks toxic. The fever spikes in a stepwise fashion. It'll be 101, then 102, peaking up at 103 to 105 degrees.
That is a terrifyingly high fever.
It is. And remember, the rash isn't there yet. It's just the fever and the 3 C's. This is the most dangerous time for transmission because people think, oh, it's just a bad cold, and they keep the kid in school or take them to the grocery store, not knowing they are spreading this incredibly contagious virus.
Right. And then the ananthem appears, the Koplik spots. Can you describe them exactly as they would appear on an exam description? I need a really clear visual.
Okay, the phrase you need to look for is grains of salt on a bright red background.
Grains of salt.
Yes. Or another description is punctate blue-white spots. They are very small. And they're on the buccal mucosa. That's the inside of the cheek, usually right next to the molars.
Salt on a red background. That's very vivid.
And remember, they are pathognomonic.
Yeah.
If you see them, it is measles. There is practically nothing else that causes that specific finding. But, and here is a catch, they disappear quickly.
Oh.
By the time the body rash is full-blown, the Koplik spots are often gone. They are a fleeting critical warning sign.
So if you missed them in the prodrome, you missed your best chance for an early definitive diagnosis.
Exactly right.
Now, the main event, The exanthem, the rash. This is usually around day 14 from the initial exposure.
Around there, yeah. And as we said, it starts at the hairline behind the ears. That's a classic starting point.
And it moves down. The term is cephalocaudal.
Cephalocaudal. Down and out. Face, then trunk, then arms, then legs. Usually takes about 3 days to fully cover the body.
What does it feel like? Is it smooth?
No, it's maculopapular. That means it has flat parts, which are the macules, and raised bumps, the papules. So it feels a little bit like sandpaper or velvet, depending on the severity. And the sources all mention that initially, it blanches.
Meaning if you press it with your thumb, it turns white for a second.
Yes. But as it progresses, by day 3 or 4, it stops blanching. The inflammation gets more intense. And in severe cases, the spots can run together. We call that confluence, especially on the face and the shoulders. The kid just looks red and swollen.
And then how does it leave? Does it just fade away all at once?
No, it's polite. It leaves in the same order it arrived.
Oh, that's interesting.
Yeah, so the face clears up first and the feet clear up last. But here's another interesting detail from the clinical notes.
Okay.
It often leaves behind a brownish discoloration and peeling skin.
Like a sunburn that's healing.
It's a similar look. The technical term is desquamation. And the brown color is actually from capillary leakage. Tiny little bits of blood cells left in the tissue. It fades over a week or so.
Okay, that is a very, very clear picture of the pathology and the timeline. So now let's pivot to the need-to-know nursing care. We are at the bedside. What are our priority assessments?
Number 1, always, is respiratory status.
Because it enters through the lungs and it comes back to the lungs.
And because pneumonia is the single most common cause of death in children with measles, you have to understand, the virus is damaging the lung lining. It's stripping away the defenses. That sets the stage for a superinfection.
Okay.
It could be the measles virus itself causing a nasty viral pneumonia, or, more commonly, bacteria like staph or strep see an opportunity and just jump in.
So as a nurse, I'm listening to those lungs every chance I get.
Every chance.
Yeah.
You're watching for retractions, for nasal flaring, for tachypnea, that fast, shallow breathing, and a huge red flag. If that fever was starting to come down and then it comes roaring back, you have to suspect pneumonia.
Good tip. What's priority number 2?
Hydration status.
This seems basic, but walk me through why it's so critical here.
Okay, so you have a kid with a fever of 105. Their metabolic rate is sky high, so they're burning through fluid. They have mouth sores, those gulping spots that hurt, so they don't want to drink. And the sources mentioned that severe diarrhea is a really common symptom as well.
So fluids are pouring out and almost none are coming in.
It's a perfect recipe for rapid dehydration and hypovolemic shock. You are monitoring intake and output strictly, checking skin turgor, checking to see if they're making tears when they cry. If they can't drink, they need an IV, period.
Let's talk diagnostics. We suspected it, we've isolated them, now how do we prove it?
The gold standard is the RT-PCR. It's usually a throat swab or a nasopharyngeal swab. The CDC protocol also recommends getting a urine sample, as the virus sheds in the urine for quite a while.
And blood work.
For blood work, you're looking for IgM antibodies in the serum. The M in IgM, you can think of it as miserable or now. It tells you there's an active current infection. The recommendation is to collect the throat swab and the blood sample at the same time for the best chance of confirmation.
Okay, interventions. We have hammered isolation, negative pressure N95. What about medications? Is there an antiviral?
Unfortunately, no. It's a virus, so antibiotics don't work on the measles itself. It is all supportive care. You treat the symptoms to keep the child stable while their body fights. So antipyretics for the fever is acetaminophen or ibuprofen.
But there is a huge warning here, and it's in every single source regarding aspirin.
Huge EE warning. Never, ever, ever give aspirin to a child with a viral illness.
Why? What happens?
It puts them at risk for Reye syndrome. This is a life-threatening condition that causes massive swelling in the liver and the brain. It destroys the mitochondria, the powerhouses of the cells. It is absolutely catastrophic. Stick to Tylenol or Motrin.
And even with Motrin, there's an age limit, right?
That's right. No ibuprofen if they're under 6 months old. The kidneys aren't quite ready to metabolize it safely. So you stick to acetaminophen or Tylenol for the really tiny ones.
Got it. Now let's circle back to vitamin A. We mentioned it in the 80-20 map. How do we administer it? Is it an IV?
No, it's usually an oral dose, a high-dose liquid or capsule. The WHO protocol is 2 doses given 24 hours apart, and if the child have clinical signs of vitamin A deficiency, like night blindness or dry eyes, they get a 3rd dose weeks later. It's incredibly effective. It helps restore the integrity of the epithelial barrier in the gut and the eyes.
Speaking of eyes, the patient has conjunctivitis and photophobia. What's the nursing action there?
Simple comfort care. Keep the room dim. Bright lights are going to physically hurt their eyes. And you can gently clean the crusty secretions from their eyes with a washcloth and warm water.
Is there a specific technique for that? Because you don't want to make it worse.
Yeah. You always wipe from the inner canthus, the part near the nose, to the outer canthus near the ear, and you use a fresh part of the cloth for each wipe. You never want to push bacteria back into the tear duct.
That's a great clinical pearl. Okay, let's run through the crash list. The big, scary complications. We mentioned pneumonia as the top killer.
Pneumonia is number one.
Yeah.
But you also have to be watching for encephalitis.
Inflammation of the brain.
Right. This happens in about 1 in 1,000 cases, so it's not super common, but it's devastating. It can cause convulsions, deafness, or permanent intellectual disability. If your patient suddenly gets very lethargic, confused, or has a seizure, that is a neurological emergency.
What about ear infections?
Otitis media is very, very common. The virus causes inflammation of the eustachian tubes, which messes with drainage. So if the fever spikes again after the rash is starting to fade, you have to check the ears. It's usually a secondary bacterial infection that needs antibiotics.
And there is that scary long-term one mentioned in the sources, SSPE.
Subacute sclerosing panencephalitis. It is rare, thankfully, but it is the stuff of nightmares. It is a fatal degenerative brain disease that develops 7 to 10 years after the initial measles infection.
Wait, 7 years later. So the kid completely recovers, grows up, goes to elementary school, and then
they start regressing. They lose coordination. They have seizures. They lose cognitive function. The virus essentially hid out in the brain tissue, mutated, and then reactivated years later. It is 100% fatal. There is no cure.
That is just heavy.
It is, and it really underscores why vaccination is the strategy here. You do not want to risk natural immunity if the potential cause is SSBE a decade later. It's like playing Russian roulette with a bullet that moves in slow motion.
Wow. Okay, so let's do a quick parent education segment. You're discharging the family. What are the absolute critical points you tell them?
First, you tell them the contagious period. The child has to be kept home from school or daycare for at least 4 days after the rash appeared. They are still shedding virus.
4 days after the rash starts, okay?
And second, you have to talk about siblings. If there are vaccinated siblings at home, they are in deep trouble. We can try to give them the vaccine within 72 hours of exposure to maybe prevent it.
Sort of post-exposure prophylaxis?
Exactly. Or we can give something called immune globulin, or IG, within 6 days. But parents need to know their other kids are very likely incubating it. You have to contact trace within the family and the community.
Okay, before we leave the core clinical section, let's hit the exam writer favorites, the traps that they love to set.
Okay, trap number 1, the absolute classic, rubeola versus rubella.
They sound almost identical. It's cruel naming.
It is. Rubeola is measles. Rubella is German measles. The little trick to remember is that rubeola has the ola in it. You can think ola equals illa. It makes you much, much sicker. Higher fever, worse complications, worse outcome.
Rubeola is illa. I like that. So rubella is milder.
Yes. My mnemonic for that is rubella is a little fella. It's generally a milder disease in children. Lower fever, the rash fades faster. Now, rubella is incredibly dangerous for pregnant women because it's teratogenic, but for the child themselves, rubeola is the illa one.
Okay, what's trap number 2?
The allergy trap.
The allergy trap.
Yeah. So the MMR vaccine contains 2 key components besides the virus, gelatin and neomycin. The exam will ask you about contraindications. For years and years, people thought an egg allergy was a problem because the virus used to be grown in a certain way. It is not a D.
Let me repeat that. So if the question says the child has a severe allergy to eggs, I can still give the MMR vaccine.
Yes. Current guidelines are clear. Egg allergy is not a contraindication. But if they have a true anaphylactic history to gelatin or neomycin, that is a hard stop. You do not give the vaccine.
That's a great catch. Okay, let's move to Section 5, Development and Milestones Impact. This is a requirement for our deep dive because diseases don't happen in a vacuum. They happen to growing kids.
Exactly. And the impact changes so drastically based on the developmental stage. Let's start with the infant or the toddler.
Okay, let's consider the physical impact first.
We talked about the mouth sores, the complex spots. Now imagine you're a 14-month-old who is just learning to self-feed with a spoon, or maybe you just weaned off the bottle. Now their entire mouth is full of painful ulcers. Eating hurts a lot.
So they might regress in their feeding skills.
Almost certainly. They might refuse solids and demand a bottle again. Or they might just refuse everything. And as a nurse, you have to be patient. You don't force the milestones. If they need to go back to a bottle for hydration, you let them.
And what about energy? I mean, a 105 fever has to just drain them. A toddler who is usually running around everywhere.
They'll be completely lethargic. They stop playing. And you have to remember, for a child, play is their work. It's how they learn and develop. When play stops, development pauses. They're just in survival mode.
So now let's layer on the hospitalization. We put them in airborne isolation.
This is huge for the psyche of a little one.
Walk us through. Why is isolation so uniquely hard for a toddler?
Okay, so separation anxiety peaks around 6 to 30 months. Now imagine you're in a strange room, in a strange bed, and the door is always closed. The only people who come in look like aliens. They're in yellow gowns, gloves, N95 masks, face shields.
They can't see smiles. They can't read any facial cues.
Exactly. To a toddler, a smile is safety. It's reassurance. If I hide my smile behind a mask, I am a potential threat. So the single most important nursing action is rooming in. You need to encourage the parents to stay 24/7. They are the anchor in that storm. If the parent leaves, that child's cortisol, their stress hormones, spikes, which actually suppresses the immune system even further.
So the parent's presence is literally a medical intervention.
It is. Now what about the preschooler, the 3 to 5-year-old?
Okay.
Their core developmental fear is bodily harm or mutilation, and they have magical thinking. If they don't understand viruses, they might think the mask means you're a monster who's going to hurt them, or more commonly, they think the illness is a punishment.
As in, I was naughty, so now I have spots.
Exactly. I didn't share my toys, so now I'm sick. It's a very concrete cause and effect worldview. You have to verbally reassure them you're not being punished. This is just a germ. It's not your fault.
And how do we help them cope with all the scary PPE?
Medical play. This is absolutely critical. Before you do a procedure, or even just when you have a quiet moment, give them a mask to play with. Let them put a mask on their teddy bear. Let them draw a smiley face on the outside of your mask, if your hospital protocol allows, or on your isolation gown.
Demystify the gear. Make it less threatening.
Turn the scary PPE into a costume. This is my spacesuit to keep the germs away from me and to keep my germs away from you.
Okay. And the school-age kid, the 6 to 12-year-old.
Their main issue is boredom and social isolation from their peers. They are missing school, missing their friends, and being stuck in one room for days is incredibly hard for them. They understand what's going on, but they feel trapped.
But we have to keep the room dim for their eyes because of the photophobia.
Right, so you can't just fall back on the easy solution and say, here's an iPad, watch YouTube for 8 hours. The screen is too bright, it will physically hurt them.
So what do? A bored kid in a dark room sounds like a recipe for disaster.
Audio stimulation. This is the time for audiobooks, for music, for podcasts like this one, or for storytelling. Get the parents to read to them. You have to find ways to engage their mind without engaging their eyes.
That is a fantastic practical tip. Don't just hand them the iPad.
Not with measles conjunctivitis. It hurts way too much.
Okay, let's move to section 6, the vaccine protocol. This is the preventative core of this whole discussion.
It really is. The vaccine is the MMR, measles, mumps, rubella, and it's a live attenuated virus.
Live is the key word there. That dictates all the rules.
Correct. Because it's a live, albeit weakened virus, we do not give it to pregnant women. Theoretically, it could harm the fetus, and women should be advised to avoid getting pregnant for 4 weeks after getting the shot.
And we also don't give it to the severely immunocompromised.
Right. Kids on chemotherapy or with advanced HIV with very low CD4 counts. Their immune system is too weak to handle even a weakened virus. It could cause the actual disease.
What's the standard schedule in the U.S.?
It's a 2-dose series. Dose number 1 is at 12 to 15 months of age. And dose number 2 is at 4 to 6 years, right before they start kindergarten.
I've always wondered, why do we wait until 12 months? Why not give it at birth, like the hepatitis B vaccine?
It's all because of mom. The baby gets a full set of maternal antibodies transferred through the placenta that circulate for the first year of life. If you give the vaccine too early, say at 6 months, mom's antibodies see the vaccine virus and kill it immediately.
So the baby's own immune system never gets a chance to see it and learn from it.
Exactly. The maternal antibodies neutralize the lesson before it can be learned. We have to wait until those antibodies naturally fade, which happens right around the 1-year mark.
That makes perfect sense, but there's an exception for travel, right?
Yes, because measles is still rampant in many other parts of the world. If you're traveling internationally with an infant who is between 6 and 11 months old, they get a dose. But the UT, and this is a classic exam point, that dose doesn't count.
It's a 0 dose.
Right. It provides some temporary protection for the trip. But because maternal antibodies might still be interfering, we can't be sure they'll get long-term memory from it.
Yeah.
So you still have to give the regular dose at 12 months and the booster at 4 years.
Okay, let's talk about side effects, because this is what parents worry about, and there's one specific thing that really freaks them out.
The mini measles.
Sounds cute. I'm guessing it probably isn't.
Well, it's not a true infection, but because it's a live vaccine, it replicates a little bit in the body. So about 5 to 15% of kids will get a fever and a mild rash. But here is the kicker. It happens 7 to 12 days after the shot.
That is such a long delay.
It is, which means the parent has forgotten they even got the shot. Then, 2 weeks later, the kid has a fever and a rash. They call the office panicking. My child has measles from the vaccine.
Right.
You need to warn them up front. In about a week and a half, he might get a little fever and a rash. That is a good sign. It means the vaccine is working. It is not contagious.
That is crucial guidance to prevent a frantic ER visit. What about the MMRV? The one with varicella or chickenpox added in.
The ProQuad. It's great for reducing the number of pokes a kid has to get. However, the data clearly shows a slightly higher risk of febrile seizures in toddlers, specifically in the 12 to 23-month age range, with the combined MMRV compared to giving MMR and varicella as separate shots.
So for that first dose at 12 months?
Usually the recommendation is to separate them. Give the MMR in one leg and the varicella in the other, just to lower that already small seizure risk. For the 4-year-old booster dose, the MMRV is fine because the risk of febrile seizures naturally drops as they get older.
Okay, we are rounding the corner to the nice to know section. Give us some context that might not be on the test, but just makes us smarter clinicians.
Let's look at history. Rhazes, who was a Persian physician back in the 10th century, was the first to really describe measles in detail. And he wrote that it was more to be dreaded than smallpox.
Wow, and smallpox was really bad.
It shows you how devastating measles was. Before the vaccine was introduced in 1963, basically everyone got it. It was a rite of passage. 3 to 4 million cases a year in the U.S. alone. Nurses who worked in the 50s remember entire measles wards. Just dark rooms filled with rows of coughing, miserable kids. It was not trivial.
It's truly amazing how quickly we develop vaccine-induced amnesia.
It is. Here's another interesting fact about the virus itself. It's fragile.
But wait, we just said it was airborne and terrifying.
It is highly contagious, but the virus particle itself is physically weak. It's an enveloped virus. That means it has a fatty outer shell. Soap destroys it instantly. Sunlight, UV light kills it. Acid kills it. Heat kills it.
So it's a weird irony. It's one of the most contagious viruses we know, but it's a complete wimp outside the human body.
A total wimp. It relies entirely on speed and stealth to get from one person to another before the environment can kill it.
Okay, Section C, cross-linking and differentiation. This is for when the exam gives you two very similar-looking options. How do you tell rubeola, or measles, apart from the common cold?
It's the toxic factor. A kid with a cold runs around, they wipe their nose on their sleeve, maybe they have a 100-degree fever. A kid with measles is miserable. They have that super high fever, the photophobia, the hacking coughs. They look visibly ill. They just want to lay there in a dark room. And of course, the progression to the rash is the final clincher.
What about measles versus chickenpox, or varicella?
The rash is the key. Measles is maculopapular, a mix of flat areas and bumps. It's red. Chickenpox is vesicular. They're fluid-filled blisters. The classic description is a dewdrop on a rose petal. If it looks like a blister, it's chickenpox. If it's red and bumpy, think measles.
And the trickiest one of all, measles versus roseola.
Yes, this is the classic timeline differentiation question. You have to look at the relationship between the fever and the rash. It's everything.
Okay, lay it out for us.
In measles, the fever is high and it is ongoing when the rash appears. They happen together. You have a high fever and a rash at the same time.
No.
In roseola, the child has a super high fever, maybe 104, for 3 days with no other symptoms. Then the fever breaks. It goes away completely. And then after the fever is gone, the rash pops out.
So fever gone, rash on equals roseola. Fever high H with rash equals measles.
That is a perfect summary. That distinction is on almost every single pediatric board exam.
We have covered a massive amount of ground. Let's head to the outro and synthesize this all into a safe bedside approach.
Okay, so you are in the clinic or the ER. A sick kid comes in.
Step 1.
Step 1, suspect it, especially in an unvaccinated child or a child who has recently traveled.
Step 2.
Step 2, isolate immediately. Airborne, get that N95 on, get them into a negative pressure room. Do not let them sit in the waiting room breathing on people.
Step 3.
Step 3, Assess. Look for the 3 C's: cough, coryza, conjunctivitis, and get out your pen light and check the buccal mucosa for those Koplik spots.
In step 4.
Step 4, treat. It's supportive care, it's pushing hydration, and it's getting that order for vitamin A from the provider.
And report it, right?
Yes, absolutely. It is a nationally reportable disease. The health department needs to know immediately so they can begin contact tracing and prevent an outbreak.
Okay, now I want to end with that provocative thought we teased in the intro. We talk about how the virus enters the immune cells, but there's new research really in just the last few years about something called immune amnesia.
This is fascinating and absolutely terrifying. We used to think that measles just suppressed the immune system while you were sick. But new studies using some really advanced techniques show that the measles virus actively hunts down and destroys your memory B cells and memory T cells.
The cells that remember how to fight off all the other diseases you've ever had.
Yes, it kills them. It essentially wipes the hard drive of your acquired immunity. So if you had the flu last year and your body built up a strong immunity, gone. If you had chickenpox as a kid, you might lose that immunity and become susceptible again.
So it literally resets your immune system to a naive, almost baby-like state.
Exactly. For months or even 2 to 3 years after recovering from measles, that child is statistically more vulnerable to everything else, the flu, strep, pneumonia, because their body forgot how to fight them effectively.
So the real cost of getting measles isn't just the 2 weeks of the rash and the fever, it's years of increased vulnerability.
It is, which is why the idea of natural immunity parties, where parents intentionally expose their kids to get it over with, is so clinically dangerous. You aren't just giving them measles, you might be taking away their protection against every other germ they've ever fought off.
That is a powerful, powerful takeaway. Measles is a big deal. It's the sentinel disease for public health, and it's a critical thinking test for every nurse.
Absolutely. So the next time you see a runny nose and a fever, don't just assume it's a cold. Check the mouth. Ask about travel. Ask about vaccines. Be the detective.
Thank you for listening to this deep dive. Go crush that exam, and more importantly, go keep those kids safe.
See you next time.